Thank you to the moderators and sages for the invitation to present. I have no disclosures for this presentation. So this is your favorite overnight call, right? This is a patient of yours with a known type 4 hiatal hernia. You've been working them up for surgery, and then they come into the emergency room with this CT scan. They have some gastric wall thickening concerning for ischemia. You do everything that you can to get them to the operating room in a timely fashion. You avoid all of the landmines that were previously discussed, and now it's your time to focus on their postoperative recovery. So for the next 15 minutes or so, I'm going to define some postoperative complications following foregut surgery. I'm going to talk about preoperative workup and perioperative strategies that may help reduce the risk of postoperative complications, as well as some management strategies for these complications. So some postoperative events that we're going to talk about include esophageal and gastric perforation, bleeding, gas bloat, nausea and vomiting, dysphagia, gastroparesis, and finally pulmonary complications. So this table is very small, but I included it to really highlight that foregut surgery generally is safe. It has a 1% or less risk of 30-day mortality and about an 8 to 17% incidence of perioperative morbidity. Before we go any further, I do think it's important to clarify or disclose that a lot of what I'm going to be talking about really is my own practice and what we do at my institution. There's really not a lot of literature about how to manage these complications. So first is your preoperative workup, which is really should be directed by the patient and what they're coming to see you for. At our institution, all of our patients get a high-resolution manometry study, and that's really to help guide the type of fundoplication you're going to perform. For any revisional foregut surgery or a patient who presents with symptoms such as early satiety, gas bloat, or nausea and vomiting, it's important that they get a gastric emptying study preoperatively. Use your resources. So for patients who have had previous imaging at your institution, especially a CT scan with IV contrast, you want to evaluate that for the potential for anatomical variants that you may encounter in the operating room. We're pretty aggressive with the treatment of extraesophageal symptoms. We work pretty closely with our ENT colleagues as well as our speech pathologists. And then you want to be prepared for the potential for a short esophagus. So use your upper GI study and your manometry study to evaluate the length of your esophagus and your lower esophageal sphincter. So some perioperative considerations. I think that this is probably the biggest takeaway from this talk. There's a lot of them that we do. So all of our patients get a scopolamine patch at the time of their arrival to the PACU. They leave on scheduled Zofran to the floor. If we use a bougie, it's a lighted bougie, and the most senior member of either the anesthesia team or the surgery team is the person who's placing the bougie. Our patients get Decadron up front in the operating room. They go home on a modified diet for 4 to 6 weeks postoperatively. We have a very low threshold for a PEG-2 placement, especially in our redo cases and our patients who have large type 4 hiatal hernias. We're pretty aggressive in treating visceral hypersensitivity. We perform 2 intraoperative EGDs. One is before your hiatal closure, and that's really to evaluate the length of your intra-abdominal esophagus and to rule out any esophageal or gastric perforation. And the second one that we do is after our hiatal closure, and we've performed the fundoplication, and that's to make sure that our hiatal closure is not too tight and to evaluate the integrity of the fundoplication itself. Also, your fundoplication type and length, that's going to be dictated by your high-resolution manometry. And then mediastinal drain placement, again, for patients who have large or chronic type 4 hernias. So despite all of these intentions, I think it's important that we recognize that bad things do happen. And so that's what we're going to talk about for the remainder of this talk. So the first is esophageal or gastric perforation. This is reported to occur between 1% to 4% of all foregut operations. There's an increased incidence during revisional foregut surgery. Some risk factors or times during your operation that increase the risk of esophageal or gastric perforation include when you're passing a bougie or nasogastric tube. For patients, again, who have large paraesophageal hernias, if you're placing traction on the sac during reduction of the sac itself into the abdominal cavity or while you're resecting the sac. And then, of course, during your myotomy, so your gastric muscle is much thinner than your esophageal muscle. The risk of a perforation is higher on the gastric side than the esophageal side. Again, use your intraoperative EGD to help rule out a perforation. If you notice it at the time of surgery, you want to repair this with absorbable suture and then consider enteral access. Typically, if this is diagnosed in a delayed fashion, it is going to require a return to the operating room or a trip to the endo suite. Bleeding, I'm not going to spend much time on. There's a decreased overall risk of bleeding now with laparoscopy and robotic surgery, as well as the use of advanced energy devices. This most commonly occurs from your short gastric vessels or a splenic capsule injury. Again, be aware of your landmines and your anatomic variants. Intraoperatively, PAC, pressure, hemostatic agents, use them liberally. This typically or rarely requires a return to the operating room. When you do return to the operating room, it's not satisfying. You typically don't find the bleeder. So if your patient's hemodynamically stable, you want to try and transfuse through that bleeding episode. Next is gas bloat. So this occurs in 1% to 85% of patients. It's more common in patients who have undergone complete fundoplication and also in patients who have longer fundoplications. This is caused by air trapping. Postoperatively, we encourage our patients to avoid straws, carbonated beverages, chewing gum, popsicles, and hard candy. All of our patients are admitted and ordered for simethicone as needed. They typically don't know that they have that medication ordered. So we do have a very low threshold for transitioning patients to scheduled simethicone. If we place a PEG tube at the time of surgery, we use that, so use it as a rescue. We teach all of our patients how to vent the PEG tube on their own so that they can use it to help alleviate some of these symptoms. Nausea and vomiting. So vomiting is preceded by nausea. Vomiting is probably one of the scariest postoperative events. It increases your risk of an early hiatal hernia recurrence and herniation of your wrap into the chest. And these patients are often miserable if that happens. So preemptive control is imperative. Again, all of our patients get a scopolamine patch placed prior to surgery. Most of our patients get induced with propofol and Decadron up front. There's some anecdotal evidence that early anti-nausea medication in the operating room helps more effectively control postoperative nausea and vomiting, so we try to give all of our anti-nausea medications earlier on in surgery. They get admitted to the floor unscheduled, IV Zofran, and then we have a low threshold for adding additional scheduled antiemetics. If the patient is continuing to vomit despite these interventions, the most senior member of the team should place an NG tube for relief of their symptoms, and then you need to get an upper GI to assess the patency of your repair. Again, if the patient has a PEG tube, use it. You can vent it to help alleviate these symptoms. Next is dysphagia. So this is a recent patient of ours who actually underwent a Nissen fundoplication that we ultimately ended up taking down. The most important kind of thing to distinguish is whether the dysphagia is from normal postoperative edema or if you have an anatomical issue. So if you have significant dysphagia, you may have a dilated esophagus on your upper GI, and then your read is gonna say something about a narrow GE junction with delay of contrast passage. So dysphagia is very common. You do have to accept a certain level of dysphagia for the first 2 to 6 weeks postoperatively. Your preoperative high-resolution manometry should guide your type of fundoplication. If you're going to use a bougie, use a large one, so 56 to 60 French bougie when you're closing your hiatus and performing your fundoplication. The risk of dysphagia is higher with a Nissen than a partial fundoplication. So again, anatomical issue, if your patient comes out and they cannot handle their secretions or you're having a hard time advancing their diet, it's likely due to an anatomical issue. Sometimes if your hiatal closure is too tight, this actually can get better with serial dilation, but if it's from your wrap, they need to be surgically revised. Gastroparesis, so this occurs in about 4% of patients undergoing foregut surgery. The risk is higher for your original foregut patients. That's why you want to get a gastric emptying study preoperatively, in addition to patients who have symptoms of early satiety, gas bloat, or nausea and vomiting. We use our gastric emptying half-life, which is 120 minutes at our institution. That may vary a little bit across institutions. This is actually an interesting study. It was done by Dr. Farrell in 2001, and they looked at patients who had known delayed gastric emptying at their time of fundoplication. Interestingly, performing a fundoplication alone actually improved gastric emptying by 38%, and then patients who underwent a pyloroplasty at the time of their fundoplication, their gastric emptying improved by about 70%. So patients who are just over the threshold for delayed gastric emptying, they may actually improve a little bit just with a fundoplication alone. For those patients, I typically place a PEG tube should they need rescue or relief of clinically significant gastroparesis symptoms. But if you're concerned at all, obviously the risk of herniation of their wrap is high if they vomit early in their postoperative period. You need to consider doing something at the time of your repair. So pyloroplasty, Botox, or an endoscopic intervention for your pylorus. And then finally, our pulmonary complications. These occur in up to 10% of patients undergoing foregut surgery. Your treatment is going to range significantly from observation alone to return to the operating room in severe cases. Pulmonary complications are more common in patients with large and chronic paraesophageal hernias, and that's because the sac itself is typically intimately associated with the pleura. So potential complications include new oxygen requirements, a capnothorax or a pneumothorax, retained hemothorax or a complicated effusion, some intraoperative considerations. If you make a hole in the pleura, make it large, you want to avoid that tension physiology. Typically, we irrigate out that fluid before we close the hiatus, and that's really to prevent leaving a fluid collection there, which may be a nidus for infection. And then if you're concerned at all, you can place a mediastinal drain or close the pleura. Some postoperative considerations, aggressive pulmonary toilet, so our patients come out ordered for an incentive spirometer and an acapella. If they're having trouble coughing up their secretions, we add hypertonic nebulized saline. We use diuresis pretty often, and then early imaging to kind of address or diagnose a pulmonary issue early to prevent needing to go back to the OR for a retained hemothorax. So in conclusion, foregut surgery is generally safe. Preoperative optimization, a patient-directed workup, and some intraoperative considerations can help make foregut surgery even safer. Complications do happen. Awareness of these potential complications, as well as early workup and intervention, can help reduce the potential associated morbidity.